Good morning, and thank you, sir, for the generous word of introduction. My topic is the total intravenous anesthesia TIVA in the pediatric patient. Is it feasible? I will cover the topic under the heading of the indications, contraindications, and pharmacokinetic differences between the adult and children and step prevention. Total intravenous anesthesia TIVA is the technique of the anesthesia where induction and maintenance of the anesthesia is exclusively by the intravenous route. Indications include when TIVA become mandatory when volatile agents are not available, as in case of remote anesthesia and patient transfer. When volatile are contraindicated, like in risk of the malignant hyperthermia and congenital myopathy, when inhalational delivery is inappropriate in case of the airway surgery and bronchoscopy, and in case of the muscular dystrophy, there is the risk of the rhabdomyolysis and hyperkalemia, and for the neurophysiological monitoring in case of the spinal and scoliosis surgery. Advantages: TIVA may be beneficial in surgery with the risk of the post-operative nausea, vomiting, children with upper respiratory tract infection, reactive airway, fear of the face mask, high risk of the emergency delirium, airway and ENT surgery to reduce the airway-related complications like bronchospasm and laryngospasm, children with the increased intracranial pressure and neuro surgery cases. TIVA reduces the post-operation room pollution. Intake, co-administration of the catecholamines and steroid and underlying metabolic disorders. But the best thing is that it is very rare under the general anesthesia because there is very rare chance any surgery run more than 48 hours. Pharmacokinetics. It is the quantitative analysis of the processes of drug absorption, distribution, metabolism and elimination. Pharmacokinetic behavior of the most of the drugs used in the TIVA can be explained by the three-compartment model. In this, drug is administered in the central compartment. So this is the central compartment. Drug distributed to the rapid equilibrating compartment with the higher perfusion rate that include the systemic circulation and plasma, and the drug also distributed to the slow equilibrating compartment with the low perfusion. That is the adipose tissue, and from the central compartment, the drug also act on the effect site, that is the brain in case of the anesthetic drug. Drug from the peripheral compartment achieve equilibrium between the central compartment and peripheral compartment. So the drug from the peripheral compartment return to the central compartment. This is called the redistribution of the drug. Here the drug is metabolized and eliminated. Bolus infusion of propofol. When we give the bolus of the propofol, there is sudden rise and sudden fall of the concentration of the propofol, and we cannot achieve the therapeutic range for much time. So this dotted line is showing this line, showing the drug of the drug concentration of the bolus, and when we give the infusion, this is the line for the infusion. There is a slow rise in the plasma concentration. It takes almost 5 plasma half-life to achieve the desired concentration. So what to do? First, we give the bolus of the drug to achieve the desired concentration and maintain this with the infusion. Bolus elimination transfer, BET principle. It is used to approximate a constant plasma concentration of the drug. Drug bolus is administered to fill the central compartment, and maintenance infusion is given to replace the drug eliminated from the body and to replace the drug transferred to the peripheral compartment. Pharmacokinetic differences in the children and adults are: children have larger volume of the central compartment, so they require larger propofol bolus and larger initial infusion rate. They require 25% higher dose of the infusion dose and bolus dose is 50% higher than the adult. Children also have larger volume of the peripheral compartment, so they require larger initial infusion rates, and there is slow recovery because of the long contact sensitive half time of propofol. Children have higher clearance rate, so they require higher maintenance infusion. In neonates have some pharmacokinetic differences from the children. That neonates have lower clearance rate because of the organs are not mature, so they require lower maintenance infusion. Some neonates, ex-premature infant, critically ill children have slower metabolism, so in these children, avoid the use of the TIVA or use with great caution. Strategy to secure IPSS. Non-pharmacological measures are parental presence, topical local anesthesia, distraction by use of the mobile or toys, and manual stabilization of the limb. Pharmacological measures include the oral or IM administration of the midazolam, ketamine, clonidine, dexmedetomidine, or nitrous oxide. Still, if IV line is cannot secure, use inhalational induction to obtain the IPSS, then switch to TIVA. TIVA can be administered by the manual dosing, bolus, intermittent boluses, or infusion of the single or combination of the drugs. Second way of the drug administration is the use of the target controlled infusion, that is TCI, and the third way is the most sophisticated way of the drug administration is the closed loop administration. Drug infusion is titrated against measurable feedback signals like this, blood pressure, heart rate, which completes the loop. Manual infusion scheme for the propofol. In case of adult, Robert and Bristol regime is the popular regime. In this, the initial loading dose is given of 1 mg per kg and followed by 10 mg per kg per hour for 10 minutes and 8 mg per kg per hour for another 10 minutes, 6 mg per kg per hour for the remaining time to achieve the target concentration of the 3 microgram per ml. But in this graph, as you can see, when we use the adult regime of the drug administration, the plasma concentration achieved in the case of the children is almost half than the adult. So, children require almost 2 times initial bolus of the propofol. Manual pediatric infusion schemes for the propofol. 2 popular manual pediatric infusion schemes are the McFarlane scheme for the children aged 3 to 11 years and Suthar scheme for the children less than 3 years of age. In obese child, adult induction dose of the propofol is related to the lean body weight and maintenance is more related to the total body weight. McFarlane manual infusion scheme. Here we can see the induction dose and initial bolus. Induction levels and maintenance dose both is much higher than the adult dose. To achieve the same concentration of the plasma, 3 microgram per ml. In the case of the adult, here it is the 2.5 and initial bolus dose is 50 mg per kg per hour. Instead of the adult, it was 1 mg per kg and 10 mg per kg per hour. Suthar regime, it is for less than 3 years of age. Here we can see the induction dose and initial infusion rate is higher than the adult, but the maintenance dose is lower than the adult. This induction dose is much higher and initial infusion rate is higher, but the maintenance dose is much lower than as compared to the adult. Target controlled infusion TCI is the system which delivers a controlled infusion of the to achieve the user-defined target drug concentration in plasma or effect site. It is based on the 3-compartment weight principle. In pediatric, only plasma targeting is used rather than effect site concentration. So, practitioner needs to allow some time to achieve the plasma and the effect site equilibration whenever increase or decrease the target level. Component of TCI infusion pump, which deliver initial bolus and subsequent infusion rates. user with pharmacokinetic software to determine the delivery rate, audio-visual safety system, user interface to select the drug, pharmacokinetic model, patient characteristic like the body weight, age, sex, and target plasma concentration. Pharmacokinetic models in the children for the propofol to widely validated and available pharmacokinetic model for children are the Kataria model and Tweed fusion model. Kataria for the 3 to 16 year and Tweed fusion for the 1 to 16 year of the age. MASH model is used for the teenage child more than the 61 kg weight. For remifentanil, Minto model is used. Adjunct to the propofol based TIVA. During TIVA with propofol, various adjuncts can be used to improve the surgical conditions, to reduce the hemodynamic response to surgical stimulus, lower the propofol related concentration, and reduce the side effect of the propofol like bradycardia and hypotension. Contact sensitive half time is the time required for the plasma concentration of the drug to reduce by the 50% after the cessation of infusion designed to maintain the aesthetic concentration. And anesthetic drugs with the lower contact sensitive half time wear off quickly. These are the better option for the adjuncts. These drugs are the better option for the adjuncts of the propofol, and the drugs with the lower contact sensitive half time could delay in the emergence. These are the drugs that can delay the emergence from the anesthesia. Monitoring of the TIVA. Vital monitoring can be done through the vital monitoring like blood pressure and heart rate clinically by the patient's movement, and effect site monitoring by the PEEG through the PIS. PEEG is the processed electroencephalography. Target value of the PIS is the 40 to 60. When to use PEEG? In children more than 1 year of age and when using neuromuscular blocking drug. Problem with PEEG are the algorithm is based on the adult EEG data and unreliable for the children less than 1 year. Latency and electrical interferences are there. Abnormal pattern in case of the cerebral palsy. Anesthetic requirement reduced in the children with the cognitive impairment. Closed loop anesthesia delivery system CLAD. The system comprises of algorithm-based software on the computer, and computer is interfaced to the vital sign monitor. Computer is interfaced to the vital sign monitor and the anesthesia depth monitor, and it is also connected to the syringe pumps containing drug like propofol, muscle relaxant, analgesic, vasopressor, and vasodilator. These are the pumps, and this is the vital monitor and anesthesia monitor. These all are connected to the computer. The feedback from the hemodynamic monitor and anesthesia depth monitor automatically adjusts the delivery of the anesthetic agents to maintain the target depth of the anesthesia. Advantage of the CLAD: there is better control of the anesthetic drug, optimum drug dosage and anesthetic depth, early recovery, avoid unnecessary anesthetic wastage, reduce workload during the busy hours, cut down the human errors, and it is an expert eye. Recovery in children commonly take longer time to awaken than the adults because of the larger size of the peripheral compartment that lead to increased contact sensitive half time. As we can see, the upper line for children, the children have the contact sensitive time higher, so there is a delay in the recovery. Safety concern: to prevent the problem with the drug delivery, ensure the IV infusion is patent and viable, keep the IV cannula visible, use anti-reflex valve, use multi-lumen contact site, minimal drug space volume, flush dead space at the end of the case, ensure the equipment is functioning properly, so ensure all pumps are programmed and functioning correctly, correct drug in correct pump and correct drug concentration, use dilute concentration of the drug, and pressure alarm should be set. Check the effect of the TIVA. When TIVA is administered outside the operation room, the same standard of the practice and monitoring should be applied as for the anesthesia in the operation room. So the question: TIVA in pediatric patient, is it feasible? Understanding of the favorable pharmacokinetic and pharmacodynamic property of the propofol and availability of the short-acting opioids, TIVA gaining popularity among the pediatric anesthetists. Propofol alone is not enough, so we should combine with the good analgesic like morphine or fentanyl until the remifentanil is available in India. PEEG monitoring is useful, but continue use of the clinical judgment and not rely on the pumps. Anesthetist should be aware of the pharmacokinetic and pharmacodynamic differences between the adult and children. Thus, TIVA in pediatric patient is safe and quite feasible, but it should be avoided in the neonate and or should be used with a great caution. Thank you.